Manjula, are we live?
We are live now, Doctor.
Okay. Okay, good evening, respected seniors, colleagues, and all the wonderful and dynamic residents who have logged in today. It gives me immense pleasure to welcome you all for the 10th masterclass of the online postgraduate teaching program called Kaksha. Kaksha is a PG teaching program by ROS, Rajasthan Ophthalmological Society, which will cover all the major topics over a period of next 2 years of the current curriculum of postgraduate training residency program in India. We will be bringing the best of national and state faculty experts to share the knowledge and interact with you all. The residents are also encouraged to put forward their doubts in a fearless manner, type their questions in the chat box, ask the questions by raising their hands, and we'll address them. Coming to this class, we have today with us my very dear friend, Dr.Sourabh Patwardhan from Sangli, Maharashtra, who will be doing a surgical audit on phaco complications by postgraduates today. Dr. Patwardhan is one of the leading cataract and refractive surgeons of India. We know each other from many years back from RP Center days. He is the director of Nanda Pai Hospital and PG Institute in Sangli, Maharashtra. They have branches in Kolhapur, Ratnagiri, Belgavi, Pune, and other places also. He is the head of phaco training and fellowship program, and he's the chief mentor of phaco tips 3D teaching course, which is a first of its kind in the world. And he's pioneering live streaming of surgeries on YouTube and Facebook for education, has many publications and book chapters to his credit. He's a great inventor too. He's the inventor of the Toric Patwardhan Android phone-based app and the hybrid chopper and the 3D surgical viewing system and the very famous phaco teaching YouTube channel, which I just saw and has more than 5,000 subscribers and increasing day by day. About his experience, he is one of the most experienced cataract surgeons of India. He has performed more than 50,000 surgeries. He specializes in cataract retina, in which he did his SASHIP from RP Center, and refractive surgery. Performed live surgeries in various conferences. He's the ex-member of Scientific and Managing Committee of Maharashtra Ophthalmological Society, and he's the invited faculty in national and international conferences. I also welcome the ROS President, Khilani Sir, President-elect Dr. Sanjeev Desai from Jodhpur, and our Dynamic Secretary, Dr. Ghulam Ali, again from Jodhpur for today's class. We have also some of our residents on the hot seat. Ayushi, are you there?
Yes, sir.
Ayushi Dhaval also, Mukesh, they are all final year postgraduates from different colleges in Rajasthan. And Saurabh is encouraged to interact with them freely in an informal way in between so that they can be kept engaged. It's not a class, it's just a discussion between you and the mentors. We have brought in the best of mentors and discussants for today. Dr. Pankaj Sharma, he's my teacher and he's the head of the Department of Ophthalmology, SMS Medical College, and one of the finest phaco surgeons of the country. Dr. Nidhi Patwardhan and Dr. Umesh from Nanda Pai Institute, Sangli, Maharashtra. And finally, there will be a grand quiz with exciting prizes at the end of the class. So keep a strong vigil and listen carefully. Over to you, Saurabh. So routinely we conduct a lecture sort of a class. This time Saurabh suggested that he will conduct a surgical audit on the phaco complications, and Saurabh will tell you what the format of the class will be. Okay, Saurabh, you can start sharing your screen and describe the format of the class.
Thank you, Vishal. Thank you so much for the kind introduction. And as you know that me and Vishal know each other quite a long time. And today, because he's my friend, I suggested him that we can change the format. And today what we'll be doing, I have asked my students and my fellows to edit some of the complications that they have seen or they have experience in their surgeries, and those edited videos I will be sharing here, and after that we can have a discussion on that complication. So I would like to invite the discussants, Dr. Umesh, Dr. Nidhi, and Professor. Also, those residents who are there, they are free to ask any question. They can write in the chat box. I can already see so many of my friends already has joined the webinar. I am sure we'll learn from this experience. So I will start with the first video. And this video is by our first year DNB student, Dr. Nilambika Kulkarni. Okay, I will share the video and then we'll start the.
Saurabh, your resident will speak about it, or you will?
We have already recorded a audio commentary, so
okay,
that will make it easier. So just let me know if the audio is.
I'll just interrupt you and welcome Pankaj sir. He is now online. Pankaj sir, hello, good evening. So you are muted, sir.
Yes, good evening, everyone. I'm sorry for the delay. There was some
no problem,
unavoidable issue.
So, Saurabh will be presenting various videos, recorded and edited videos of complications. Okay, sir.
Okay.
So here goes the first video. Just let me know if the audio is properly played or not.
Hello everyone. This is Dr. Nilambika and I would like to discuss a case of CCC Extension. As you can see, this is an intumescent cataract and fluid comes out as soon as the capsule is punctured. After aspiration of this fluid, the surgeon uses the microrhexis forceps to create a small central rhexis. Firstly, viscoelastic is injected to flatten out the capsule and then a centripetal pull is given to the capsular flap to avoid any extension of the CCC. This is particularly important in this case as the pressure in the bag and the zonular pull have a strong tendency to pull the rhexis towards the periphery. Also note how the surgeon is re-holding at the root of the capsular flap each time. This helps in making a controlled CCC. Cruciate puncture can also be done in this case. After completing the smaller rhexis, fluid pockets are aspirated from the main incision and the side port. At this point, the surgeon can rotate the nucleus to release the fluid that is trapped posterior to it. Milking out of fluid can also be done. Now, to extend the rhexis, micro scissors are used to give a nick, and then forceps are used to slowly enlarge the CCC. The surgeon is giving a tangential pull to the capsular flap. The surgeon is also making a rhexis of around 7 to 8 mm, which itself increases the risk of it extending into the zanules. After replenishing viscoelastic and forming the chamber, the main port is being used for further enlargement. But as you can see, pressure is being applied at the tunnel, which is causing an opening of the wound and thus visco is leaking out. This in turn is making the chamber shallow. Look what happens as the surgeon tries to enlarge the CCC in a shallow chamber. The CCC has extended into the zonules. On replay, we can see that the surgeon was not holding at the root of the flap and a slow tangential pull was being given, thus causing the CCC to extend. A left side port was made and another nick was given to the capsule on the other end. Forceps were used to complete the remaining CCC. Nucleus is gently rotated and prolapsed with the help of a Sinski. Visco is injected above and below the nucleus and it is delivered with the wire vectis. Rigid IOL is placed in the bag. To summarize, the two do's include heavy OBD, small CCC or a cruciate puncture to avoid extension, and a quick central pull to bring in the extending rhexis margin. Thank you.
Okay. So this was the first video. So we can start with comments by Professor Sharma sir. So you can comment on the video and we can go ahead with that.
I think the main problem is the use of viscoelastic. I was just observing that HPMC was being used because now we have got Indian counterparts of sodium hyaluronate which are cheaper and they are much more accessible. and 1.4% is available, freely available, you should use that first of all, so that we can press on the anterior capsule and make it as less convex as possible. Secondly, instead of making a small CCC is a good idea, and to aspirate the cortex and reduce the pressure from inside the nucleus, from inside the lens. But then sometimes even a small nick can suddenly extend. So the best, what I generally do is take a 26 gauge needle, bevel down, and then aspirate just by entering it very gently without any lateral movement, so that we can decrease the pressure inside the bag, and then further augment with the sodium hyaluronate in the anterior chamber, and then the CCC can be completed quite easily. I have a video. You can give your comments. I'll search for my video.
Yeah, I think we'll finish all the videos because we have 6 of them.
Okay.
So I think the key take-home message from this, in fact, the first part, which was the double rhexis. So initial, the small rhexis was properly made. As Sir rightly pointed out, heavy OVD is the choice nowadays. We should not rely only on HPMC because we have good alternatives available. But even after making a small capsule rhexis, I think the surgeon did a mistake that he didn't rotate the nucleus completely properly, because there is a lot of fluid which is trapped behind the nucleus, and it has been shown in literature also that trapped fluid is in fact the cause for the extension, because the moment it starts pushing the nucleus up, that is when it goes out. Now, the second thing, even after removing the intumescence from the cataract, still the surgeon had extension. And that was because of the visco leak, and surgeon tried to use the main port and press the posterior lip of the incision down. So that rhexis extension would have been possible even in non-intumescent cataract. So in fact, the surgeon took good care that he should avoid extension in a intumescence. But after removing intumescence also, surgeon had that complication because he just did not attend or was not mindful while enlarging that capsule rhexis. So it's always important that till the entire process is over, you should not relax. You should complete properly, with thinking that anterior chamber should always be maintained whenever you are doing capsule rhexis. So I think that is a take-home message. Yes, Dr. Umesh or Dr. Nidhi, you would like to have any additional comment on this?
There is a question actually, that what is the advantage of cruciate incision in this case?
So double rhexis technique is very useful technique in most of the cases, but it will not prevent the Argentinian flag when it happens, when you just touch the capsule and then you try to make a small rhexis. At that time also sometimes Argentinian flag can occur. So in very, very intumescent cataract with very shallow anterior chamber, it's better to have a cruciate incision, because the pressure is exerted on multiple points and not just on one point. I think a similar innovation was done by Dr. Rajendra Prasad, where he made a central small opening using the sewing needle, or like a round needle, where you have basically a crenated kind of central opening. So the pressure is not exerted at one single point, but at multiple points. So I think that is also a good option in such cases. And one more option, like Professor Sharma sir said, is that immediately doing aspiration the moment needle enters the intumescent lens. And you can use either a manual aspiration, or you can connect it with the phaco tubing also, and you can use your foot switch to aspirate the fluid. The main issue happens when there is a dry tap, and these are the cases where in fact there is a higher risk of extension. So when there is a dry tap, you have to be very, very careful, and in those cases heavy OVD helps, because with HPMC, if there is a dry tap, once there is a tap, that means you aspirate everything out, it becomes a normal cataract, and then you can do anything. But when you cannot do a tap, those are the cases where you have to be extra careful. And then in those cases, definitely make a very small rhexis, rotate the nucleus around. Maybe you can even do little bit of phaco or IA, so that entire nucleus, the amount goes down, and then you can increase the rhexis. So every intumescent case is slightly different. So I also described one test. I call it visco press test. The moment you inject a heavy OVD on the anterior capsule. If the anterior capsule becomes flat, then that lens is not actually intumescent. That means you can do routine tap and then you will not have any problem. But despite injecting heavy OVD, if the anterior capsule remains convex, you have to be extra careful in those cases. So just after injecting visco, see in 3D, you can actually see whether the anterior capsule is flat or convex, and be careful once you see a convex capsule. Okay. We'll start with the second video. If there are any questions, just post on the chat box.
I will also request all the students to watch the 4-step technique of doing CCC in intumescent cataract by Dr. Sourabh. This is the technique that we follow here in our institute. And it has hardly, we have seen any case of CCC extension in intumescent cataracts in our institute currently.
Just one small point is that
Yes.
whenever you are completing the capsular rhexis with a forceps, usually a forceps is good because you can give both tangential as well as circumferential retraction, but always remain close to the leading edge so that you can control it. Never work away from the leading edge, otherwise it will inadvertently go away.
Yes, perfect. Okay, I will start with the second video.
We'll be discussing about phacoemulsification in compromised CCC. So side port incisions was made. Now as you can see, during this main port incision making, there was shallowing of anterior chamber and the keratome entered the anterior capsule and this tear happened. Then staining was done by trypan blue dye. Tunnel was deep and there was premature entry. So in this incision site was sutured. And another main port incision was made at temporal side. Now cystotome is used to start the rhexis up to one side of tear. Micro scissor is used to make the neck and micro rhexis forceps is used to complete the rhexis. Another side port incision was made. Minimal hydrodissection was performed. Nucleus was managed with trench and divide technique. Now as you can see, sideways sculpting was done without nucleus rotation and 4 quadrant was made. Then aspiration was performed under low phaco parameter. After this cortical aspiration, IOL is placed in a way so that haptic will align away from extended capsular tear to prevent decentration of IOL. Extra flap was removed and chamber was formed. There is another case also where similar complication occur. And tear extended up to periphery at 3 sites. So 3 different neck is made by micro scissor and then rhexis was performed. Nucleus was then managed similar to previous one, and since this was hard metcat and there was high risk of extension of tear to posterior capsule, so IOL is placed in sulcus.
I'm sorry, I can't hear anything. Hello.
Yeah, sorry. So I was muted. Yeah.
Yeah.
So I think in this video, two cases were shown. I think the starting point of complications were while making the first entry, the keratome touched the anterior capsule. So what were the risk factor? This we see sometimes in the beginners who have less control over the insertion of this keratome. So what are the precautions that the surgeon should take? Yes, sir.
Should I speak? I
Yes,
think
sir.
the main problem was that the main incision was being given in an aqueous-filled chamber. So as soon as the entry was made, aqueous came out, and still the surgeon persisted with completing the incision or even slightly enlarging it. So the shallowing of the chamber occurred, and then the anterior capsule got stuck in the tip of the keratome. So always the eye should be hard, solid hard while making the main incision, so that you remain in the proper plane and there's avoid sudden shallowing. But if for some reason, if the CCC has extended into the periphery, then there are two or three things one should take care of. One is the capsule complex should be freed from the nucleus and the cortex, so that whatever your rotation you do, it doesn't put undue stress on those zonules and extension of the rexes. Whatever pieces you make, they should be small, and large pieces should not be prolapsed into the anterior chamber, because that force can cause extension of the CCC. And thirdly, I think you should prevent shallowing of the anterior chamber. That also promotes the extension of the anterior capsule into the posterior capsule. I think if you keep these things in mind, everything can be managed.
Yes, I think, and one of the things which when I analyze these videos of keratome or even sometimes MVR, making even the first incision with MVR, where it's always aqueous filled and the MVR may touch. That's because what the beginners do is that when they make an entry, they take a very long time to take that knife out. The moment knife enters the eye, you should take it out immediately. So that should be the reflex. What if we go back and see the videos, you will find that surgeon has entered and took a very long time to take that knife out, and that is the time when the AC shallows and the tip, the anticapsule touches. So even if you are making the side pore entry, the moment you enter the aqueous, I think you should immediately withdraw the knife. So that should be the reflex that you should learn. I think in both the videos it was perfectly shown, like sir said, that no the force should be transmitted to the torn capsule. And another thing, in both the cases, the surgeon made a larger opening in the anterior capsule. You should not continue with the with the tear, because then there is a bigger anterior capsule there and forces can be transmitted. So make something like a rhexis on both sides and then continue. Another good technique in such cases is supracapsular phaco, where if the nucleus is very soft, then you can gently just prolapse it in the anterior chamber and then aspirate it out. But of course, avoid in very hard cataracts. If this happens with very hard cataract, maybe those who know SICS well, I think that is the best way to go forward in this case. I think any other point, Dr. Umesh, you would like to? In fact, Dr. Umesh was the one who managed both these cases very nicely, as you can see. And the second case, actually, it's called a Mercedes-Benz sign. So where you have tri-radiate, cut, and you have to look at all the 3 points when you are operating. So one of the good signs, I think Dr. Rohit Om Prakash has described, is the flap flutter sign. So If you see any of the flaps which are turned inside, then that is the time when you should be worried. If they are fluttering out, like that means they are, everted, then you should not be worried about its posterior extension. Dr. Umesh, you would like to add anything in the discussion?
Yes, sir. I found that the soft nucleus will be managed very easily by these techniques, but for harder cataract, it is always wise to go for SICS cases.
Yes. There is a question how to confirm that proper hydrodissection was done in first case as rotation was not performed. So in these cases, you have to do very gentle hydrodissection, making sure that you do not increase the anterior chamber pressure. You can do multi-quadrant hydrodissection, and you need not necessarily keep on rotating the nucleus initially. As you start doing phaco, the fluid will itself, separate the nucleus from the capsule. And once you know that the nucleus is free, then you can start rotating. So it has to be very gentle. So you should avoid the kind of rotation that you generally do when the CCC is intact. So thank you, Dr. Vaishali, for that nice video. We'll move on to the third video. One second, I will share it. So the next video is by Dr. Kishan. He is a first year CPS student in our institute, and his video is on PCR.
Hello, good evening everyone. I am presenting a video on PCR during the epinucleus removal. 5.5 mm CCC was made by the cystotome. Hydrodissection was done. Surgeon rotated the nucleus clockwise and anti-clockwise by the Sinski. Successful rotation was done. Now surgeon was started the trenching from the middle part of the nucleus. Now we can see carefully, surgeon was not achieve adequate depth of the trench. Still he was trying to separate the nucleus into two pieces. This is first mistake by the surgeon. Second time surgeon was make deep trench to the proper depth. Still he could not achieve the proper depth. We can see the bowl-like nucleus was formed because not achieve the proper depth of the trench and not separate the posterior pole of the nucleus. Surgeon was emulsified nucleus by the phaco probe. Nucleus was removed. We can see only epinucleus cell was remain in the bag.
Okay, I will just hold it here because there is a very important point which might be missed by the in the commentary. If you see the CCC size here, in fact, it's not 5.5, it's a very small CCC, just maybe 4 to 4.5. And now when you go to this part where, the second half is being emulsified, you can see it's huge. So whenever you have a small CCC and very large, big piece at the end, that is, you're asking for trouble. So let's see what happens next.
The epinucleus cell was remain in the bag.
Now, whenever this happens, just look at the springiness. The moment the surgeon tries to, take that piece and emulsify, there is springy. So the moment it is held, it again is pulled back because the capsulorhexis is not allowing it to move forward.
Was fight with the epinucleus. Phaco probe slowly emulsified the epinucleus with the high vacuum. This stage also will increase the risk of the PCR because of the phaco punch. Actually, during this situation, use the bimanual or coaxial probe instead of the phaco probe. We can see the fluctuation of the PC and some cortical debris was seen behind the PC due to the fluid misdirection syndrome. Phaco tip touched the posterior capsule. The PCR and happened. PCR was 12 to 2 o'clock. Now we will discuss how to prevent this type of the situation. First, the low bottle height and the low vacuum. Zero phaco energy during the epinucleus removal. Left hand Sinski under the phaco probe tip to prevent the phaco probe tip does not touch the posterior capsule. Aspirate the epinucleus cell above the iris plane. and use the bimanual or coaxial probe. Visco injected into the anterior chamber before removing the probe. IVT was injected to stent the vitreous. Now anterior vitrectomy was performed in gut irrigation aspiration mode for the vitreous. The parameters are highest cut rate around the 3000 to 5000 cut rate. Bottle height should be kept 60 to 70 cm and vacuum should be kept 150 to 250 mm. Gentle cortex aspiration is done by IA cut mode for the cortex aspiration and parameter was low bottle height and low vacuum. Main incision was extended. Residual or 3-piece IOL in sulcus because of the PCR was too large or maybe extend to the equator. So reason behind that the IOL implantation in the sulcus because of the optic capture through the capsular axis. Suture was taken because do not further prolapse of the vitreous into the anterior chamber and maintain the anterior chamber. So lastly, state acetazolamide 250 mg given for the maintaining the IOP. Thank you.
Okay. Yes, sir.
I think the main problem with a PG doing his phaco is that when he assesses, he sees the experienced surgeon doing the phaco in one go. He enters the anterior chamber, completes the phaco and comes out. So the PG thinks that it's the way to do it. Here, what he was calling the epinucleus was not the epinucleus. I feel it was some amount of nucleus was there still in that thing. As you said, the CCC was small. So the pieces which were the remaining were the last piece was quite large. It was springing back and forth. So at that point, you should just teach them that to remove everything, put some HPMC in the anterior chamber, take a Sinski from the main port and slightly float the small piece in the anterior chamber. Then if you again take the phaco needle inside, the pressure will again push the nucleus down. So first from the side port, take a small Sinski and just keep that small whatever nucleus piece or epinucleus is there up, and then put the phaco probe in and then gently emulsify it. A slow motion phaco, or what he said that was two-step phaco, which was propounded by Dr. Vasavada, that once the pieces are small pieces left, more capsule is exposed, you bring down the parameters, use viscoelastic, and then do it very gently. Don't try to follow that small piece into the capsular bag. Invariably, it will just eat up the small piece and then the capsule also.
Yes, sir. Dr. Nidhi, you would like to add anything?
Yeah, we very commonly see this case as a case of PCR. And whenever we see a very large, thick epinuclear plate, you can say, or a thin nuclear sheet, which is difficult to chop or difficult to trench in the end, then we ask the trainee to stop. And most of the time, what I do is, if the CCC is slightly adequate, at least 5 mm, then I ask the epinucleus to be placed perpendicularly so that one edge is visible. And then we make the power to 0, low vacuum settings. And then we ask the trainee to take the nucleus from one edge so that the nucleus piece is vertical. And then the phaco probe has to be kept fixed in the center. And then if we want, we can add 5 or 10 power. And then controlled emulsification can be done. So now one edge is there in the nucleus probe. So that is generally, I have seen that it is a technique which can be done by most of the trainees.
Yeah. So I think small rexis or is the starting point of many complications. So it's always important because nowadays we hear in the conferences that optic should be covered 360-degree with CCC, etc. But that is okay in the later stages. I think when you are learning, I think it is best to have good big CCC, at least 5 mm is must before you go ahead with other steps, because the moment you have a small CCC, the fluidics inside the bag is always compromised, like in this case where there is a big piece and a small CCC and you are trying to. Yes. Another thing, as Dr. Ayushi just mentioned about fluid misdirection or, fluid collection behind the posterior capsule, that happens. I think that even Dr. Kishan mentioned in the video. So here what we saw in the video was that even before the last epinucleus was getting aspirated or phaco was done, we could see few cortical, particles behind the posterior capsule, which indicated that some fluid has already went into the Berger space, and that is very common when you are nearing the last pieces, because then the entire nucleus is almost out and only these pieces are remaining. And if there is fluid behind the space, in the Berger space, what happens? PC becomes more redundant and it starts fluctuating. So recently in, I think 2020 or 21, there was a Russian paper which mentioned that anterior hyaloidal separation is one of the risk factors for posterior capsule rent when there is a last piece. So I think that we should always watch out for. So if you have a microscope with good retroillumination, you can always see the PC which is fluctuating or more redundant, and you can see these tiny particles in the antivitreous or in the Berger space. The moment you see that, you always reduce all the parameters and make sure you do a slow phaco for the remaining pieces. Okay, so with that, we'll move on to the fourth video. Okay, so this is by Dr. Chinmay. Let me share it. So Dr. Chinmay is a fellow in our institute. And so this is a case of Zanular dialysis. And let's see how it was done and what.
Good evening, everyone. So this is a case of Zanular dialysis during nucleus rotation. So here we have a case of small pupil with pseudo exfoliation with pre-existing zonular weakness. So our plan for this case is to use iris hooks, keep a CTR ready, keep an iris claw or an SFIL ready, and as a last resort, convert to an SICS. So here the iris hooks have already been placed and the surgeon is initiating a CCC. As you can see, the rhexis margin is going too close to the periphery. Now the surgeon is using forceps to complete the CCC. The question at this stage is whether capsular hook should have been used. Now hydrodissection is being done. The surgeon is attempting nucleus rotation. As we can see, during nucleus rotation, there is excessive movement of the bag. Along with that, zonular dehiscence is also noted. The question is whether CTR should have been inserted at this point itself. So now what we can see is that there is more than 12 clock hours of zonular dehiscence and should have been ideally converted to SICS. But nevertheless, the surgeon goes ahead with the trenching. And during trenching, what you can see is there is excessive movement of the lens bag complex. With increased trenching, there is more and more stress placed on the zonules. Now the surgeon is attempting to divide the nucleus, but as you can see, because of the weak zonules, the nucleus division is difficult and the entire bag moves. So what are the signs of ZD? The difficulty in CCC, visible zonules, excessive bag movements during various phaco maneuvers. So how do you treat a ZD? So in case of a less than 6 clock hours, you can use a CTR, use low power phaco and bimanual maneuvers. So now this case was converted to an SICS. The surgeon is making a tunnel with a crescent blade. Now using a keratome, AC entry is being made and the side pockets of the tunnel are extended. To extend the tunnel on one side, one of the iris hooks is removed and the tunnel is extended. Remember that we have to cut while going in. Now the surgeon is going to attempt to remove the entire lens along with the bag. So with a wire vectis is inserted below the lens bag complex and the lens is removed in 2 parts. Some visco is being placed over the vitreous. The main port is sutured. Iris hooks are removed. Anterior vitrectomy is done after staining with triamcinolone. some visco replenished again, and now we are attempting to implant an iris claw lens. From the main port, the lens is inserted into the anterior chamber over the iris. Now using the forceps, one of the haptics is being enclaved under the iris. Now the other haptic is being enclaved under the iris. Now the iris claw lens is in place. A peripheral iridectomy is being done. And now the case is closed. Thank you.
Okay, so sir, you can comment, and Dr. Umesh, you are there?
Yes, sir.
Yes, you can also share your views on this video.
I think the basic problem was that the hydro was not properly done. So the nucleus was not actually freed from the capsule complex, the capsule itself. And then excessive forces were applied to rotate. And they were, the surgeon persisted with that excessive force even after the dialysis had occurred. So everything had already gone haywire initially only. I think the important thing is to do a multi-quadrant hydro dissection, which should be a subcapsular delamination. We should not go into the nucleus. It should be very subcapsular so that the smooth capsule is separated from the subcapsular cortex. And while rotating, you should try to use two instruments, one from the side port, one from the main port, so that minimum stress on the zonule in such cases of pseudoexfoliation is done. And then, because if we keep two Sinskey hooks or one chopper and one Sinskey at two extreme ends and then give a gentle couple of forces, then the rotation can occur, but provided the hydro has been done properly. I think that was the main mistake.
Yes. Dr. Umesh?
Yes, sir. Sir, especially in zonular dialysis cases, we can prevent by doing good hydrodissection, as sir said. Also, bimanual nucleus rotation is also very important. And especially hard cataract pseudoexfoliation cases, non-dilating pupil cases, we can put a precautionary CTR if the surgeon is not that much experienced. And that's so.
Yeah, I think in cases of where you are sure that you are going to keep the bag, I think best to put CTR in the initial stage only. Only in cases where you feel that, the zonules may be so weak that I have to remove the bag. In such cases, I would prefer putting capsular hooks to support the area where the zonules are weak. And believe me, the moment you put capsular hooks, you will find that the bag gets so much of support. It's like a normal phacoemulsification, even better than that. The anterior chamber is very stable. And you can complete the phaco, then assess whether the bag is, you really want to keep the bag with a CT segment and CTR there, or you just want to remove it and then maybe put a SFIL or iris claw like in this case. So I think you should have capsular hooks in your OR to be used in such cases. It would have made all the difference in such case where initially zonular weakness was maybe very, in a smaller area, got extended because of the manipulations over the period when the manipulations were being done. So I think pretty good case. So Dr. Nidhi, you want to add anything?
Dr. Sourabh, I wanted to ask, what stage in this case should we have put the capsular hooks? You're muted.
Yeah. So in fact, I don't put CTR right away in most of these cases. I always use capsular hooks, complete the phaco, I assess that how is the bag behaving. Then I go ahead with CTR because, it's best. Once you put CTR in the bag, then it is like you are committed to keeping the bag there, because it's very difficult later to remove the CTR, though it's possible. But if you have a, say, PC rent when you are doing phaco, and then you already put CTR in the bag, then you are in a, trouble because you have to remove the bag, and then CTR may be left behind during that. So that is what. Yeah, so I think Dr. Jitendra Vidhani sir is asking whether you have to put CTR in all PXF cases as a precautionary measure. So what I do in cases of PXF, one thing what I have seen is that smaller the pupil, that means lesser the dilatation of the pupil, the chances are more that zonules are going to be weaker. So if you have very small pupil to begin with, which is not dilating, and patient has PXF, patient is likely to have more zonular weakness. Okay, so in such cases, what I do initially, I take just after putting putting the dye, staining, and then putting the viscoelastic, I take a Sinski, put it on the center of the capsule or the nucleus, and then I just move the bag little bit and see how is the movement. If the movement is too excessive, I know that the zonules are so weak that I may not be able to keep that bag there. So I just change my mode of surgery. I change it to either I do small incision cataract surgery and go ahead with iris claw or SFIL, or I use capsular hooks, complete the phacoemulsification, and then think about whether to keep the bag or not. So this simple test, just go in, just hold the put the Sinski in the center of the nucleus and of the bag, and just move it little bit around, and you will get to know how much zonular weakness is there. So you get to know even before you start the capsulorhexis. Of course, when you do the capsulorhexis, that time also you can get generally fair idea what the zonular status is and how much the nucleus is or the bag is moving.
Just 2 points more for CTR. I think if the CCC is very small, then the CTR insertion is maybe more traumatic. And secondly, whenever one plans to put the CTR, it should be with an injector system because it produces least stress on the remaining zonules. I think that should be important.
Yes, sir. So I will move on to the next video now. So the next video, 1 second, I will just play the video. So the next video is by Dr. Ankita. She is a post-DO DNB student in our institute. And this video is about iris prolapse. So let's see.
See what happens when bad things get worse. Here, a female patient was undergoing a small incision cataract surgery. The tunnel was of correct depth and had a long enough entry for the nucleus to be removed easily. To deliver the nucleus, a wire vectis was inserted. Watch the wriggling motion of the vectis, which caused iris tissue damage. An undue pressure was exerted on the incision's lower lip while still being well inside the anterior chamber. This caused dragging of the iris out of the tunnel. Then he tried pushing the iris back with the visco cannula and noticed that it was in fact underneath the iris tissue. Here, the iridodialysis was noted. At this point, when the nucleus was delivered and iridodialysis was noted, a foldable lens could have been injected by enlarging the side port incision after suturing the tunnel. Now watch the tip of the iris repositor carefully. Here you see the root of iris being avulged and pushed into the anterior chamber, causing extension of the dialysis. Now each time the pressure in the anterior chamber is increased, the iris will prolapse. Repeated handling of the iris tissue was done. Implantation of intraocular lens in such cases becomes even more challenging as it leads to further iris tissue handling and causing tearing of the iris, leading to a large iridodialysis. Pull the iris tissue from another incision site and slide the repositor gently over it. In such situations, the goal should be to handle the iris tissue as little as possible. Now, the visco wash was performed at high parameters and the iris tissue was pulled further by the aspiration cannula. Let's watch another case. The anterior chamber is overfilled with OVD leading to prolapse of the iris. By releasing OVD from the side port incision, the anterior chamber is decompressed and the iris is then tucked back inside. The iris once more prolapses upon nucleus delivery attempt, indicating a premature entry. Then, to prevent overstretching of the iris tissue, the nucleus is delivered with gentle viscoexpression. Using low parameters, the cortex is removed and the side port incision is widened to insert a foldable intraocular lens. Among the circumstances that can lead to iris prolapse, a deep tunnel, premature entry, overfilling the anterior chamber with OVD, fluid misdirection and an entrapped hydrodissection fluid under the nucleus are some of the common causes. Decompress the globe in these circumstances. Inject heavy density OVD over the iris tissue. Pull the iris tissue from another incision site and slide the repositor gently over it. Suture the incision site and begin irrigation only after the probe has fully entered the anterior chamber. For minimal handling, try inserting a foldable intraocular lens from an incision that is away from the damaged iris tissue. Use low parameters for visco wash. Don't make a bad situation worse. Avoid further complicating the complication. Thank you.
Okay, so that was an interesting video because two similar cases were shown. Yeah, so okay. So Dr. Nidhi, Dr. Umesh, you would like to comment on this video?
One basic concept of iris prolapse, which everyone of us should understand, is that if there is anytime there is iris prolapse, that means that there is the pressure inside the eye which is increasing and which is causing the iris to come out. So the common tendency to put the visco, that should be avoided. First, that is very important, because as soon as you put visco, you are increasing the pressure inside the eye again, and more iris will prolapse out. So the first step is to make it hypotonous. So if there are other side ports are there, then you can decrease the IOP from there, and then it will go inside very easily. Then you decide if the tunnel is very bad, and it is better that you put the iris inside, and you if the nucleus has been delivered, that you suture it, and then do the cortex removal and the lens insertion from other port only, so that the iris damage extension can be avoided.
Yes, I think it's a common temptation for surgeon. The moment iris prolapses, all the attention of the surgeon goes to, put that iris back. And, every time it prolapses out, again, it is put back. And in all that, maneuvers, the iris gets further damaged. So I think just make sure iris is back in the hypotonous eye, and then suture that incision, or don't use that incision for further maneuvers. Use some other incision and complete the case. Okay, so that was a good point. Dr. Umesh, you would like to add anything?
Dr. Sourabh, you are muted.
Hello, Dr. Umesh. I think he's muted. Am I audible? Hello, am I audible now?
Yeah, you are audible, Saurabh.
Yeah, I'm audible. I think Umesh is muted. Okay, so we'll move on to next case. There are no other questions. So this is the REA.
You can ask the residents whether Ayushi, Mukesh, anybody else has any queries regarding this case. If everything is clear, then we can proceed.
Yes.
Ayushi, everything is clear?
Sir, the use of adrenaline during this phase is helpful in making iris tough and matte.
Yeah, so basically once you touch the iris, nothing else really helps. It becomes atonic in that area. So none of these dilators help, because in that area the muscles fail to, contract. So I think as we see commonly that once the iris becomes atonic, there is no way you can, maneuver it better by using anything else. Yeah, but in some cases, like for example, if the iris prolapse happens even before nucleus delivery, like in case of SICS, sometimes we can use iris hooks to just pull those, that iris back from the area of the incision. So just pull iris back and then you can deliver it without damaging the iris. So that can be tried in some cases.
Sir, in some floppy iris syndrome cases, iris comes out from the tunnel as well as the side port, sir. So how to manage those cases?
Okay, so the floppy iris, again, as I was mentioning, it's a atonic iris. That means there is no tone for the iris. So the iris will follow the pressure gradient. If you make an incision in a tensed eye, or you have made already an incision and then there is a pressure gradient across the anterior chamber, that means then the iris will, go into that incision. For example, the fluid starts going under the iris. It's a atonic iris and the fluid is passing from a side port incision, which you might have made much bigger, and the instrument which is going through that is smaller. Then the iris will go and get into that incision. So in floppy iris, it's best to use a pupil expander right from the beginning. If you feel that the iris is going to be very floppy, that will solve most of the issues. And second thing is always avoid that pressure gradient across any incision. So I have the video, maybe at the end I may show. It's on my YouTube channel also, the 11 different ways to avoid these problems in floppy iris. And one of the procedure which I do during phaco particularly is that I call it phaco insertion and removal ritual. So it's like a ritual, So when we are introducing the phaco probe inside the anterior chamber in a floppy iris, you should always enter without irrigation on, because what happens when you start the irrigation and try to go inside the incision, the irrigation always enters the eye even before the probe or the probe enters. So the moment irrigation goes in, and if the tunnel is not completely occluded by your phaco probe and phaco tip and the sleeve, then the iris will go into the incision. Okay, so that is one thing. So the phaco entry ritual is stop the irrigation, make sure the AC is nicely formed with visco, but not overfilled. Avoid overfilling of viscoelastic. You can put little bit of heavy OVD just underneath the incision, that is the iris, which is just in front of, and then enter the probe and then start the irrigation. So this is phaco entry ritual. And what is phaco removal ritual? Before taking the phaco probe out, stop the irrigation. Let the eye become little bit of hypotonus and then remove your phaco probe. Okay, if you do that, then you avoid the iris following the probe when you are removing the phaco. So if you follow, and there are many other things which can help in floppy iris.
Thank you, sir.
Okay, any other comment or question, or move on to last video? Okay, so maybe after the last video, we can have more discussions. So the last video is by Dr. Amog. He is a retina fellow, phaco plus retina fellow. So he is showing a case where there was a nucleus drop and then how it has to be managed.
Full scenario to happen in every phaco surgeon's practice, that is PCR with nucleus drop. Overall incidence of PCR in literature, even in the hands of experienced surgeons, is about 0.45 to 3.6%. Hence, early recognition of PCR is important to avoid dropping of nucleus, making matters worse. Large PCR, pubescent nucleus, and pre-existent liquefied vitreous can increase the chances of drop after PCR. Here is a phacoemulsification surgery performed by a trainee of moderate experience with grade of cataract NS2 to 3 with good pupillary dilatation and stable capsulozanular complex. The surgeon employed trenching and chopping maneuvers for nucleus management and was initially doing quite well. While separating the last piece, there was PCR which wasn't realized and the surgeon continued to emulsify the last piece. And what happened next in the next split second was missed. On careful observation, by slowing down the video, we can observe that the pupil momentarily snapped. This is known as the pupillary snap sign, described originally by Ronald Yu, which is a momentary posterior iris displacement occurring when fluid collected behind the nucleus bursts through the PCR. Having not detected the PCR, the surgeon continues the phacoemulsification and the piece anterior to the PCR started to tilt and quickly fell off into the vitreous cavity unnoticed. Even though the piece was soft, at this point the surgeon should have stopped, used a visco shield strategy with dispersive OVD and proceeded with low phaco power, vacuum and irrigation to prevent further damage. Abrupt probe removal without prior OVD injection can cause sudden AC shallowing, causing further PC tear extension with vitreous prolapse into the AC. After suturing the main phaco incision, thorough anterevitrectomy with lowest vacuum and maximum cut rate settings should be performed with no pulling away movement of the cutter. Panic-stricken sudden phaco probe removal and attempted fishing out of falling nucleus pieces should be avoided. After performing thorough anterevitrectomy, 3-piece IOL was implanted in sulcus and VR backup was called for. T-port 25-gauge pars plana vitrectomy was performed. Core vitrectomy was performed and the drop nucleus piece was completely separated from any vitreous attachment whatsoever to prevent inadvertent pull over the retina before phaco-fragmentation. At 3 mm distance, a sclerotomy incision was made parallel to the limbus with 22-gauge MVR. To prevent any pull over peripheral retina, sclerotomy site was cleared of any incarcerated vitreous. Drop nucleus piece was lifted into the mid-vitreous space and easily emulsified. Peripheral retinal examination was done with 360 degrees scleral depression to look for any missed peripheral retinal degenerations or breaks, and peripheral vitrectomy was completed. Surgery was ended by closing the sclerotomy site with 70 observable Weichel sutures in a box configuration with 211 throws. All's well that ends well, but prevention is always better than cure.
Okay, so that was the last case. Dr. Umesh, Dr. Nidhi, comments?
The method of the cause of PC rend was similar to the case of the thick big epinucleus plate. Here also the very big pieces were kept, and the surgeon tried to take one big piece. So again the same mistake, that he went to the center and did not properly align the nucleus piece, and actually this could have been easily chopped, that's a big piece. So these things could have been avoided.
Yes, Dr. Umesh.
Yes, it generally happens more commonly when you're aspirating the last few pieces. So we can prevent this by injecting a good amount of visco. You can lower the parameters phaco setting and then do slow phacoemulsification. So this can prevent the last piece drop.
Yes, okay. If there are any other questions, you can write in the chat box. Dr. Vishal, I think we are through with all the videos.
Saurabh, I have a few comments to make. For the,
yes.
You have a in-house VR setup, and most of these residents will be practicing in the periphery.
Yes.
Where the VR setup will not be available. So the take-home message is not to fiddle and fish with the vectors in order to take out the last nucleus piece if there is a rent. Just leave it there. Maybe do anti-vitrectomy, maybe place the IOL in sulcus, but do not enlarge the incision. Just put a suture and refer it to the VR colleague out of your center, so that things do not become messy and it's a clean job, because these surgeries are very routine and excellent result can be achieved if the primary surgery is clean and referred in time with a single suture.
Yes, yes, perfectly said. Yes.
And second thing, I just wanted to know, why did you make a third incision for the phacofragmentum, and why did not you enlarge the active port of the vitrectomy in this case?
Yeah, so that's what I generally do. That is to because once we have taken out the nucleus piece, generally we inspect the periphery, and if there is more skirt of vitreous, we remove it. So what I feel is that if you have enlarged, like if you are not using the trocar cannula system for that remaining, then that part keeps leaking, and we may have vitreous incarceration in that port, which, like, you must remember that earlier we used to use 20 gauge vitrectomies a lot, where there was no trocar system, and few cases used to get that port side dialysis or vitreous incarceration, which nowadays we don't see, because now we use trocar cannula system quite often. Of course, just one of the possibilities, and I'm used to it, because that port anyway is sutureless, so we don't have to suture that and just remove it.
There is a question about what settings you prefer for phaco-fragmentation during nucleus drop during vitrectomy.
Yeah, so I use
Is it the same as
50%.
the phaco settings, or it is dependent on the nucleus hardness?
Yeah, so generally you don't need that much of power inside the vitreous cavity. So I generally start off with 50% power. It's important to use pulses rather than continuous phaco power, because you don't want to repel. Because unlike, you might be using Ozil for phaco, where there is no repulsion, but the phaco frag which we use is always a longitudinal phaco, so it will have a repulsion. So it's always better to use pulses, so you have better, once you occlude the tip, it keeps on eating the phaco pieces, you don't get repulsion. Use good amount of vacuum. Make sure that the globe doesn't collapse. So generally, when I'm using Constellation, I raise the IOP to around 40 and raise the vacuum to 150 to 200. So there is less repulsion, and I don't have to move the probe around and keep fetching the pieces, and it comes off in less time. So those are my settings.
Excellent. And the one more thing I would like to add, that it is a sleeveless tip. So you should always be wary of scleral burns, especially in hard nucleuses. You keep on irrigating that area, but just coat that fragmentum tip with visco while inserting it. So it keeps the edge of the contact cool, the sclera and the tip contact. So the burn incidence is less, so that your suturing would be fine after the surgery.
Yeah, so I think it's better to have slightly larger scleral incision. It should not be very tightly fitting. And of course, sclera is much more resistant for burn as compared to cornea, but and there's always some leak when you have slightly bigger incision. So it should not be very snugly fitting. If your tip is snugly fitting, two things happen. One is that because when you are trying to incision is small, you may create unwanted dialysis or this thing, choroidal tear or choroidal separation there. So make sure that you have adequate incision.
Exactly. Okay, Saurabh, now it's the quiz time. I suppose you are ready with your quiz questions.
Yes.
So the format will be that you will just show the quiz question or the photograph, and we'll give around 5 to 10 seconds to answer, and whoever answers it first in the chat box will get a grand prize powered by Antort Pharmaceuticals and will be delivered to his or her workplace.
Okay. So 1 second, I will just check.
And it is open to all the attendees, whether it's the resident or a practitioner, everybody can participate in the quiz.
Okay, 1 second. How to share that particular show windows. Okay, that's the quiz. So this is the first photograph, and what is the spot diagnosis?
You get around 10 seconds. We have a lot of responses.
This is a tough one. I would say look
not as
at
simple as that.
Complete picture.
I think some shadow is coming over the picture. Can you just...
Okay, sorry. Yeah. Okay, now better?
Yeah.
Yeah,
okay,
now I think it's...
Okay, Saurabh, the answer is?
Wait a second. I will check whether anybody has answered. Okay, yeah, there is one answer.
We have PPC, pseudo exfoliation, PSC, sunflower cataract, silicon oil, PC.
Yeah, so the answer is sunflower cataract, and it happens in.
It happens in.
And you can see, I think the answer KF ring is also given. You can see that KF ring. It's in fact quite significant KF ring. So it's a Wilson's disease. Okay.
So Neelambika Kulkarni has answered it correctly. Congratulations, Neelambika. And your prize will reach your workplace very soon.
Should I move on to the next?
Yes, please. Second question.
Yeah. So this is, you can see and you can answer.
The time starts now. Time is up.
Okay. Anybody has answered?
Ethylene pearls, emulsified oil.
Yes.
Oil, pearls.
Yeah, it's emulsified silicone oil.
So one is oil, and I would say emulsified silicone oil is the exact answer, right?
Right, yes.
So Salva Cathcart, if I'm pronouncing his name right, is the right answer. Congratulations, Salva. You are the grand prize winner, second of Kaksha 10.
Okay,
Thank you,
so
Saurabh. You can
I have
sharing.
one more photo just for fun. There is no prize.
Yeah, please.
But anyway, I have made the, so yeah, so this is easy one, but you have to give the right answer.
This is not a prize question, just for fun. You can answer your the question in your chat boxes. Alport, PPC, PSC, calcified anterior capsule, posterior lenticonus.
Yes.
Posterior
So
lenticonus,
the answer is
PPC.
posterior lenticonus. Perfect.
Excellent.
A rare condition, but yeah, that's the answer. Okay.
Any queries to Dr. Sourabh, Dr. Nidhi, Dr. Pankaj Sharma, sir? Okay. So this has been, Saurabh, you can, this has been a wonderful Kaksha on evaluation and audit of surgical complications of cataract surgery. It's a vast topic, as we all know, and it's impossible to cover everything. But nonetheless, it was a very well explained and a very comprehensive video presentation, Kaksha. Thank you, all the residents, ROS executive, respected teachers. Thank you, Saurabh, Nidhi, Umesh, Pankaj sir, and for the excellent teaching. We look forward for the next class in the coming week with more residents in the hot seat. Thank you, and keep giving your feedback and suggestions for the Kaksha experience to improve. Do subscribe to our YouTube channel ROS Online for updates and the recorded Kakshas. Good night from Team ROS, and
yes.
Thank you, Saurabh. Thank you, Nidhi.
Thank you, Dr. Vishal, for the invitation, and thanks to our students and fellows.
You are excellent collection of videos, and I wonder how do you get all the time for this editing and voiceovers and all these captions.
This was all done by our students.
Yeah, but you must be mentoring them to do that, no?
Yes.
Great work, Saurabh.
Okay. Thank you. See you and good night. I hope everyone enjoyed. Bye.
Excellent.